Okay, our next speaker is Dr. Offie Soldin. Dr. Soldin completed a Master of Science degree in pathology at Tel Aviv University of Medicine in 1986. She came to Canada the following year for postgraduate training at the University of Toronto and subsequently obtained her PhD from McMaster University in molecular virology and immunology in 1991. In 1994, she completed an MBA in Management, Science, Technology, and Innovation at the George Washington University School of Business in Washington. Dr. Soldin is widely published, has received numerous awards for her research, and has served on editorial boards of professional publications and as a member of professional, advisory, and community groups. Dr. Soldin is currently Associate Professor of Oncology and Medicine, Division of Cancer Genetics and Epidemiology, and the Division of Endocrinology and Metabolism at Georgetown University. Her research interests include environmental effects on hormone changes and on pregnancy, steroid and thyroid hormone changes in pregnancy, and levothyroxine kinetics. Please join me in welcoming Dr. Offie Soldin.
Thank you very much for inviting me here and for this introduction. I'm going to share with you some very specific studies that describe innovative ways of approaching pharmacokinetic research in pregnancy. And this was conducted only at Georgetown University by myself and by my husband, Stephen Soldin. So everybody who recognizes the name, yeah, it's him. So this was funded by NIH, by the National Institute of Child Health and Development, and by the Office of Research on Women's Health, and also by Georgetown GCRC. This is a grant today, it's called the CTSA. This is basically 100% funded when the women are admitted, so it's not part of my grant. I'm now continuing these studies with a new R01 that I received in September from the National Institute of Aging of all. So the background is that thyroxine, as you all know, is both a hormone and a therapeutic drug. So we have a basic problem, because using conventional methods of analysis, it's impossible to differentiate between the endogenous hormone and an exogenously administered drug. So what we did in order to conduct pharmacokinetic studies, we decided to basically label the drug. For determining the appropriate use of medicines according to their characteristics, we conduct these pharmacokinetic studies. And thyroxine has a special problem because we know from reality, from clinics, that there is an increased need in supplementation of all hypothyroid women of 50%. So as soon as the woman becomes pregnant, there is a need to increase the drug by about 50%. We don't know if it's 50% or not, so we do need to personalize it, and we don't know when exactly to do it. And thyroxine is especially necessary in order to supplement neurodevelopment in the fetus. So these women who are hypothyroid, severely hypothyroid, give birth to mentally retarded children. So in the United States and Canada, North America, it's unheard of. But in Africa and some places in Asia where there is severe hypothyroidism, and the women's diet is based on goitrogenic substances such as soy and other cassava, these women literally give birth to cretins in the millions. This is not so well known here in North America. Now, in Europe, a lot of the women are iodine deficient, and they are very aware of the problem of hypothyroidism and pregnancy. So the objectives of our studies were to conduct pharmacokinetic studies of levothyroxine and to use the hypothyroid patients in order to see how much of the change is happening in them normally. So it's opportunistic in the sense that these women are hypothyroid and are supplemented anyway. And we use their own prescribed dose. So if the woman takes 100 micrograms per day, thyroxine, as you well know, is a daily medication. They take it once a day. We used 100 of the drug. And we conducted these pharmacokinetic studies in these women longitudinally. So we used the same woman as her own control. So she came to us first time as a pregnant woman, and the second time after she gave birth, at least 3 months after she delivered, so that she's balanced back. The challenges were to conduct the PK studies using the traceable form of levothyroxine, and the other challenge, which was our real challenge, was to measure the very, very low concentrations of this levothyroxine because we used a single dose. So at the very, very beginning, just the word stable isotope, which is what we used in order to use a traceable form of levothyroxine, just the word isotope was a big barrier. So I started with the FDA, and I found the person who's in charge of all these studies of levothyroxine at the FDA. And I received within 1 day, believe it or not, it was faxed back to me, that at the FDA they have a rule that if there is an approved drug, a stable isotope format of this drug is safe in pregnancy. So stable isotope, just as a definition, is a non-radioactive format of this, of the element that we're using. So when we use the levothyroxine that was using a stable isotope, and I'll show you the molecule in a minute, it used carbon, which was carbon-13. And carbon-13 is just a stable, non-radioactive format of the carbon atom. Then we had to have the protocol approved by the Georgetown University IRB. And since all of the studies were conducted at Georgetown University, I had no further problems. But since then, we used Georgetown University IRB as the IRB of record. So if we conduct any study anywhere else, we just use the Georgetown IRB as our IRB of record. And this is, I'm conducting some studies in Israel, at Washington Hospital Center, which is not our hospital, at Mayo Clinic, at Harvard, even in Greece. We use our own IRBs, our IRB of record, and if it's approved in our IRB, the other IRBs usually automatically approve it and just have their own informed consent form for the patients to sign. So here's our molecule. And so all of this is levothyroxine. This is actually thyroxine. And what it means, levothyroxine, is actually the normal thyroxine. It's just synthetically made, but it's the same. What you're missing right here is a double bond with oxygen. So there is an external ring and an internal ring. And there are 4 iodines, 1, 2, 3, and 4 here that you can't see. This is why it's called T4. And in this ring here is where we put the stable isotopes. So this point right here, 1, 2, 3, 4, 5, 6. These 6 carbons are labeled with carbon-13. This can be read using the tandem mass spectrometer. So, and that's what was, these studies, these were measured using that tandem mass spectrometer at our bioanalytical core lab, and that's the major issue of measuring it. When one of these iodines is removed, LT4 or T4 becomes T3, and T3 is the active molecule. This is the active thyroid hormone. I did put here, for those of you who have a question about the stable isotope, the half-life of carbon-13 is about 500 million years. And it possesses no harmful or radiation-related effect. It is safe for use in children and in pregnant women. This has been used, I called the IRB, our IRB, to ask if anybody's ever used stable isotope in our university, and they found in 1976 somebody used it in dietary zinc studies in children, in pediatrics. So I called him, it was Siva Subramanian. I said, Dr. Subramanian, do you happen to have a form of your informed consent? I just want to use the language of how you describe the use of a stable isotope. He says, no, but if you find it, please, I'd like a copy of it. So actually, the person who helped me with the language with that was actually Neil Benovich, who does conduct, in California, who does conduct studies with using stable isotope in smoking. So the format was from there, just to make the women believe that it's not harmful. The second I was convinced of it, I had to convince the nurses, the recruiters. And once they were convinced of it, it was no problem at all, because the women themselves are not finding it difficult. I did have to change the title of the study, and instead of saying studies with the use of stable isotope, just studies, pharmacokinetic studies with levothyroxine, and that did it. C13 levothyroxine, and levothyroxine itself, the derivative, is highly stable and it doesn't convert to C12 levothyroxine. I know this is one of the questions that I was asked often. So the C13 is very stable. It does not refer back to C12 levothyroxine. Now, once we had that, I had to have that synthesized for me, and it was synthesized in Isosciences in the United States. And once that was synthesized, I had major problems. The study was halted for 6 months until I found a way to administer the drug to the patients, because it was synthesized in the form of a powder, and I had to have it compounded. So I found a compounding pharmacy who could put it in a capsule for me. So they put it in a capsule, and the most well-known levothyroxine that's administered to patients today is Synthroid by Abbott, but that's bound to lactose. And so women who are lactose intolerant have some problem with that. So they use microcellulose in their capsules. Now, all of the studies and all of the prescribing information that we had from Abbott for the drug, for levothyroxine, and these are published and you can find them over the internet or the drug insert, show you pharmacokinetic studies. But these pharmacokinetic studies are conducted on men, usually IV. There's about 6. It's done on 6 people. Now there's some studies in women, but you don't even know what age. But usually IV. And what they do, since they can't differentiate between the drug itself and the hormone, they give super large amounts of levothyroxine. So since we have in the room here, say 100 people, I'm sure 3 or 4 of you are on levothyroxine, because about 3.5% of people are on levothyroxine. The normal amount, the median amount, is about 100 and 125. They conducted it with 600 on healthy people. So a person who's not taking any of the drug would receive 600 micrograms of the drug for several days. They did it for 3 days. Because of the half-life of levothyroxine is about 7 days. And it was enough to reach a plateau after, to have 4 points on the curve. So these studies, in order to calculate the pharmacokinetics, had to compare 600 compared to 450. That's how, and then they extrapolated it to give the amount, the pharmacokinetic curve. This is not what I wanted to do. I wanted to have a single dose pharmacokinetic and to give them their normal amounts. So we put 100 in these capsules. And for example, I have a patient on Tuesday that's coming in, and she's on 125. So she's going to get 1 capsule of 100, and she's going to get a pill of 25, just to complement it. But when we do the calculations, we calculate the 100. So these capsules are kept in room temperature, in a dark room, in a desiccator. And I send it to quality controls once every 6 months to a special standardizing pharmacy in Texas, actually, where they do this. And the research pharmacy is the one that administers the drug to the patients. The patients are admitted in the morning. I think I have it here. The results I'm going to show you is 9 women, but we've now done 16. These women were rendered euthyroid by levothyroxine replacement. They were recruited during pregnancy, and the target therapeutic TSH levels were maintained at around 1 milli unit per liter, so they were stable. The exclusion criteria is to make sure they're not anemic, so they had to have a hematocrit larger, this sign here is wrong, larger than 28%. TSH should be lower. We excluded them when it was lower than 28%, and TSH was higher than 4.5. And if they had kidney dysfunction, they're excluded. If these women were on any other drugs that could affect the thyroidal axis interactions, such as drugs that may alter TSH and thyroid hormone secretion or transport or metabolism, they were excluded. Now, I don't expect you to see this, but I can just tell you from what I see here that some of the women were in the first trimester, some in the second trimester, some in the third trimester, and one of the women we started as non-pregnant, she was trying to become pregnant. Not a good idea because these women who are hypothyroid have some difficulties in getting pregnant. Some were white, 2 were African American. So there is variability, and the gestation weeks, as I said, are different. The only dietary requirement that we really insisted on is that they discontinue any multivitamins that contain iron, because it's well known that the absorption of levothyroxine changes if there is iron in the diet. And they needed to fast from about midnight. They show up at about 7 o'clock in the morning. We do their hematocrit again in the morning when they show up. We give them their pill. They're not supposed to take their own pill. And then they get breakfast about 2 hours later, and they stay there for 12 hours. And after 12 hours, we send a nurse or one of my research assistants to their home. So they're first consented, then they're giving their own dose, and then the next day they can take the pill anytime they want. And whoever comes to their house to draw the blood comes at day 1, 1 day later, 24 hours, 2, 3, 4, 5, 6, 7, and even 2 weeks. Even that took us some time because we didn't know how long we could trace the drug, but we can trace it all the way to 2 weeks. So in each of the days, they can take the drug whenever they want. It doesn't matter to me anymore because I'm only following that dose that I gave them. So the method using the tandem aspect I don't think is of interest here, but and it's published. The one thing that I'm not sure you could see here, but can you see these results here? Yeah. Yes. Okay, so basically what I'm showing you here is that we take the first sample at time 0 before they take the pill, and then half an hour after, 1 hour, 1.5, 2, 2.5, 3, then 4, 6, 8, 10, 12, and then 24, 48, 72, 96, all the way down to 2 weeks every 24 hours. But what's really interesting too is these are the levels that we can measure. And we, at the same time, because it's a chromatogram that comes out of the tandem, we can measure the total T4 and we can measure the total T3. So we can tell if they were compliant the day before or not as well. And we can also see how it changes. But what you can see here is actually a bit unexpected because the results that are shown in the literature is the Tmax, the highest concentration and time is usually after 3 hours. That's not what I saw, not what I got. So you could see it starts peaking, but it peaks after, here in this woman here, it peaked at 8 hours. And and I'll show you the mean result. This is what the pharmacokinetic curve looks like for a non-pregnant woman. And as you can see, these are the samples that we took consecutively in the first few hours. This is 10. And then every one of them, we wanted at least 4 points on a straight line. So the data analysis was actually conducted in Ohio. Sander Vinks did most of it. And later I used people at the FDA. to do the pharmacokinetics for me, and using both Winolin and non-MEM modeling. And this is the summary of the results. The Tmax in hours was about 8 hours, not 3, which is why I did the sampling at 1, 1.5, 2, 2.5, 3, and 4. I wanted to catch it. And then the Cmax was a little different between the pregnant and non-pregnant, but the area under the curve was very different. And this is the clearance. And this is supposed to, and this was done at the FDA, the statistician at the pharmacokineticist, is looking at a percent change in C13 in area under the curve. And these are non-pregnant women, and these are pregnant women. This is for each woman. So it's not consistent, but all of them, the change in the area curve is much, much, much higher than in non-pregnant women in these ones. Can't tell you exactly right now before we conduct the statistics of the 16 women. Another comparison that we looked at is the gestation week to see how the area under the curve of the ratio between the pregnant and non-pregnant women changes. And as you can see, at 13 weeks, the ratio is 1.03, but at 36 weeks, it's 4.15. So it grows as the pregnancy increases. So our conclusions, we were successful in conducting these PK studies of a single dose levothyroxine at the patient's level doses in non-pregnant and in pregnant women. The area under the curve was significantly higher during pregnancy than in the same women about 6 months postpartum. And the increase in levothyroxine area under the curve during pregnancy could be attributed to a decrease in the levothyroxine clearance. And these preliminary results also suggest that the levothyroxine pharmacokinetics changes significantly with the gestational age, and there is a large variability in the pharmacokinetic parameters in pregnant women and a relatively narrow range of variability in non-pregnant women. This is very important because levothyroxine has a very narrow therapeutic index. And we need more patients, and as you know, I do have a little more patients now. And on the basis of these preliminary results, I have already submitted a proposal for an R01, which was scored, and I will resubmit it perhaps in September, October. And I have successfully received an R01 where I use these results to do pharmacokinetics in aging, because we do know that something changes in aging because TSH increases as we age, but we don't know why. So the mechanism responsible for gestational differences in PK is still another thing that needs to be investigated, and whether these should necessitate dose schedule changes in pregnancy. One more point, levothyroxine is not metabolized using CYP enzymes. It's metabolized by the diodinases. The diodinases are different in each tissue, so it's at the tissue level done. And so there's a lot more studies that could be conducted, and I'll be happy to furnish any questions perhaps later because we're running out of time. I just wanted to thank all these people who helped me, and especially Steve Soldin, who did most of the tandem mass spectrometry studies, and Don Madison, who was a major champion of conducting studies in women in pregnancy.